Alright, so chapter 14 is metabolic, and these are the unknowns for the chapter. So first one looks fairly normal. The first thing that I notice is that we're sitting on acral skin, right?
Mm-hmm.
So that's a nice tip to some of these, just because that's probably the most common location that this occurs. So from this power, what do you see?
Looks like amorphous material.
Yeah,
and like
so
inflammation around it.
Good. So like some sort of palisaded granuloma, maybe,
Mm-hmm.
with some sort of amorphous pinky gray material kind of in the center. And as we go down on higher power, that's exactly what you're seeing. So you're seeing granulomatous inflammation or palisaded granuloma surrounding all of this stuff. So what do you think that this is?
Probably gout.
Good. So this is gout.
Casting.
And what happens is that actually formalin destroys the crystals during processing, which is why you get this weird, you're not really actually seeing that feathery amorphous
It's
stuff
like
is
what
not
was
gout
there.
material, is not the actual urate crystals. What it is kind of all the feathery clefts that are left after they dissolve out. So if you're really thinking that something is gout, the best way to actually cement it is in alcohol.
Okay.
And we can fix it in alcohol. Or you can send it to us in saline and saying, gout, please, pretty sure it's gout, please fix in alcohol.
Okay.
And that actually preserves the crystals. So we just do it without the formalin. And they're actually kind of cool. So do you remember what they talk about urate crystals, how you recognize them?
Yeah, it's like I'm trying to remember which one it is with what. With the
So they're the
polarizing
needle.
filter.
So they're the needle-shaped, negatively
Negative
birefringent. So everybody says that, and that's great and all, but what does that actually mean? So when you put the polarizer parallel, they're yellow,
Okay.
and if it's perpendicular, they're blue.
Blue.
So because some crystals are just birefringent and are the opposite. So good. So that one was an easy one. And sometimes it's easy to overlook when you think that there should be something else going on. Alright. We have a dirty slide. Okay, so first thing you notice about this is what?
A lot of mucin.
Okay, so yeah, there is a lot of mucin in this one, and a lot of them there's not this much. But the first thing I notice is look how thick that biopsy is, right? So look how thick the dermis is. That's your first clue. And then, yes, when you actually go down and take a look, this blue stuff in here is mucin. You could stain it if you really wanted to. I'm not sure that you need to at this point. Where is it situated?
Pretty deep down.
Right, so most of the mucin is deep. What else do you notice? Does the dermis look hypocellular, hypercellular, pretty normocellular?
I would say maybe normal to hypo.
Okay, so I think it looks pretty normal. There's nothing in here. There's a little bit of inflammation perivascularly, but I think that's fairly non-specific. But I don't feel like I don't see any fibroblasts or dendritic cells, right? You see a fair number of them. There's not too many of them. So thick biopsy, deep deposits of dermal mucin.
Scleredema.
Yep, good. So
What
this is
are the
scleredema.
mucin stains? It's like
Colloidal iron?
Colloidal iron.
Is the one that we use most commonly. You could use MUSC carmine, but that one is pink, and so sometimes it's a little bit harder to pick it out from all of the other pink stuff on the slide.
Makes sense.
But the colloidal iron turns it blue. The only thing you have to pay attention to is that if you have a lot of solar elastosis, which we don't in this one, colloidal iron also stain solar elastosis. So you have to make sure that you can differentiate what is what. And just throwing that up there does not necessarily, will not necessarily clarify things for you. So this one is pretty legit. And so with this
Probably
one, a lot of times,
Not quite this obvious.
Yeah, no. A lot of times all you get is just this faint increase in space between the collagen bundles, and so you have to have a fairly good suspicion that that's what you're looking for in order to do the mucin stain. So what is sclerodema associated with?
A monoclonal gammopathy.
So it can be a monoclonal gammopathy. What else can cause it?
Diabetes.
Diabetes. So that's a big association. What's the other one?
Strep.
Strep. Good. And then this is usually found where in your patients?
On the back.
Good. Perfect. Any questions about sclerodema?
I don't think so.
Okay. I saw you missed with gout.
Oh, okay. And that's the feathery.
Yeah, the feathery amorphous material. If we have enough time, we'll go back over it.
Yeah.
Okay. What do you notice here? Sorry, I'm going to get this back in focus for everybody at home.
Pink material in the papillary dermis.
So I think that that's fairly normal papillary dermis, actually.
Maybe more wispy
Yeah.
collagen bundles.
So, you know how I was talking to you about that more subtle
Yep.
change? Yeah. This is a good example of that more subtle change. All you kind of see is maybe some wispy collagen bundles in here and maybe some increased space between the collagen bundles. Right?
Mm-hmm.
But where is this one predominantly located? Versus like the last one. This one goes up probably, right?
Yeah, more
so more, superficial
diffuse.
reticular dermis is where it seems to be situated. It's not a thickened biopsy necessarily. Okay?
Mm-hmm.
So, what do we think?
Is it myxedema? Is that enough?
Mm-hmm. So this is pretibial myxedema. And so, like I was talking about, the way that you differentiate it from sclerodema is that it's not deep. It's like the full thickness of the dermis is where you get all of the deposition of things. And there is some mucin in here. It's not nice, nicely blue as the last
I
case.
feel like I don't see the mucin as prominent.
You don't in this one. But it's the fact that, do you see all these white spaces?
Mm-hmm.
Is there usually a white space like that in the reticular dermis?
No.
No, you usually have bigger, thicker collagen bundles, and they're usually pretty close together. So that's your clue, that there's some sort of something deposited in here, right? But then those wispy collagen bundles, and the fact that it's the whole dermis is what gives you.
And then stasis myxedema was in the, or stasis mucinosis was in the differential in the book. It was like,
Yeah.
And that's just more superficial.
Yeah, that's
like,
more superficial. The blood vessels up here do look a smidge thick, but you'll get more of your actual stasis changes where you get those really rigid,
nodule.
superficial blood vessels and that sort of thing too. So, good. Okay. So, number 4.
So there's a lot of, I guess, like pink material.
Mm-hmm.
So, where is it situated?
More so, I guess,
Papillary
papillary dermis.
Papillary dermis, good. So, what does that make you think of? Is it cellular?
No.
No.
Not really, right? It's kind of that amorphous, acellular, eosinophilic material. What does that make you think of?
Amyloid.
Good. And what type of amyloid? What else is going on that gives you kind of a hint? What does your corneum look like?
Thickened.
So hyperkeratotic.
Mm-hmm.
What does your epidermis look like?
Acanthotic.
Acanthotic. So hyperkeratosis, acanthosis, plus what's probably amyloid tells you
So lichen.
what. Yeah, so lichen amyloidosis. Good. And so where does that usually occur?
On the leg.
Yeah, so it's usually like the shins, the anterior, lower legs,
Okay.
and it's very itchy.
How does EPP look compared to this? Because that's kind of like what I was thinking along the line.
I'm sorry, what? EPP?
Yeah.
So you really shouldn't have the amyloid deposition. Does that make sense?
Mhm.
And I don't know if you guys looked. There's a B slide to this one. Was it? No, sorry. We'll get to the B slide. So what would you do if you wanted to prove that was amyloid?
Stain her up.
With what?
Congo red.
Okay.
Crystal violet.
Okay.
Thiboflavin.
Thioflavin T. Good.
Pagonia or whatever.
Pagoda
Red. Yeah.
Yeah. So there's a lot of them. So with Congo red, what are you looking for?
The red, like the brick red stain.
So brick red stain and what else?
Apple green birefringence.
Apple green birefringence. Good. And with the crystal violet?
I don't know.
So you're looking for the metachromatic staining of it. So, because everything looks really purple, and so you're looking for that metachromasia in the stuff that you think is amyloid.
What color will it stain then?
So it's more of that. So I think of it as being like everything looks really purple, and then you kind of get this pinky purple, kind of magenta purple type of. I don't know. It just looks different.
Okay.
It looks different than the surrounding
purple
stuff, right?
Okay.
It's like more multicolored than it is like straight purple. I prefer Congo red, but that's just me and just what I've been trained with. So.
Okay.
But they do say that a lot of times Congo red does not pick up as well the amyloid in the skin, the cutaneous amyloid. And what type of amyloid is like an amyloid?
Keratin.
So it's keratin derived. So it doesn't necessarily mean that they have systemic amyloid. It doesn't mean that they have some sort of plasma cell dyscrasia or anything like that going on. Okay? Alright, so number 5. So what pattern do we have going on here?
Superficial and deep.
Good, so superficial and deep, and then what does that kind of take you into? Superficial and deep, what, perivascular? Right?
Mm-hmm.
Yeah, the perivascular, and then there's
around some of the
sweat.
mm-hmm.
So, yeah, good. So, and then we have it in the eccrine coils. So what should be...
Tumid
Good.
lupus, yeah.
Exactly. So in this one, we do have interface. Right?
Mm-hmm.
You do have a little bit of interface, and that's okay for tumid lupus. A lot of times you won't have any interface to help you out. But you should never have significant interface in a tumid lupus. Then it's a different type. But yeah, so good. Superficial and deep, perivascular, periannexal, dermatitis. What else is all in here, which is a nice plasma cells. So it's nice when they're there. You also have to remember that sometimes it's site specific, so it doesn't mean as much. And then what's probably in here if we were to stain it up? Mucin. Good. So there's probably increased mucin. So we've done tumid lupus before. I think I did it with you guys. So any questions about that?
Nope.
Okay. Okay. So what do you think is going on? What strikes you?
So there's that fissured material in the pachydermis.
Good. So pink, amorphous, acellular. It is nicely fissured, and sometimes that's a good hint. Let's see if we can find. What else do you have going on here?
Pigment content. Or melanocytes.
So is it melanophages, or could it be something else? Because it looks kind of refractile to me. What else makes brown pigment that's more refractile than melanin?
Hemosiderin.
Hemosiderin. Good. So sometimes it can be melanin, sometimes it can just be hemocydin, but that type of histiocyte rooming is sometimes a nice clue.
There's more of it.
Mm-hmm. What else do we have in here, though? Plasma cells. So that's also a nice tip. Sorry.
This is the nodular.
This is the nodular. And what does that mean? What type of implications does that have? Do we have to worry about this one?
There's about a 7% chance you do.
Why is that?
Because it can go on to... It's an AL, so it can go on to...
Good. That's what I was trying to get you to come to. It's an AL type of amyloid, so there could be a plasma cell dyscrasia lying beneath it. So you do have to evaluate these guys, okay? It can be purely skin and mean nothing, but you still have to go and do the workup. Alright, and this is the B. So what stain do you think this is?
Congo red.
Congo red. Good.
Cool.
See if we can get it to do it. Helps if we put that in.
That's cool.
Looks sort of apple green.
Yeah.
It does.
It does. I'll move my arrow out of the way so it's not influencing anyone. So yeah, so that's that apple green birefringence that everybody talks about. You do have to be careful and make sure that you're in the amyloid when you're looking for it, because collagen can sometimes do it, which is not very helpful. But this is clearly within the amyloid. And then just based on the brick red staining without polarizing it, that's probably the most positive Congo red I've ever seen in my whole life. So, alright, so nodular. This should be everybody's favorite, because you consistently call me in on the weekends. Just kidding.
Least favorite.
So, this is obviously a deep biopsy, right? More of like an excisional kind of fat pad almost type of biopsy. Not typically representative of what you guys take or send.
Calciphylaxis.
Yeah. So, it is calciphylaxis, and you can see the calcium deposits. And where does the calcium deposit?
Sure. Small.
So, yeah, so in the capillaries, in the very small capillaries in the subcutaneous tissue. So all of these are outlining a lot of the capillaries. But it doesn't, you can see here, it doesn't really ever affect the big vessels, right? So we care about, if you're going to go look for it, you have to go look in the small vessels in the sub-Q. What else do we typically see, which is a nice clue to go along with it? I'm not sure I saw any in here, though, when I was looking before. What else in the vessels would be nice to see? Or typical to see?
Is it thrombus?
Yeah, so thrombi. They usually go right along with it. So I didn't see any clear-cut thrombi here, but sometimes it's really nice when you see that. So, and you can get necrosis in the biopsy. And so if you take a punch from the densely necrotic center of one of these, and we may or may not be able to help you. So if you're going to take one from the center, that's great, but take one from an edge or something that looks more living, yes, as well.
4 of them. They're about 4.
And just make you gotta get sub Q. So if you wanna double
do it.
punch and put some elbow grease behind it. So good. Any questions about calciphylaxis? Alright. This one technically wasn't in this chapter, but I think it was in the last chapter.
In the chapter before that.
Was it? What is it? No one should have a problem with this one.
Bananas.
Bananas. Yellow bananas in the skin.
Chocolate
so
bananas.
So good. So, ochronosis. Good. And what is the inherited condition?
Calcinuria.
Good. Alkaptonuria. I really hope that's a question on your in-service or your boards or something, because you all will never forget it. Okay.
Thank you, James.
I just hope you remember things.
What did James say for that one? I wasn't here that
He thought he was saying, Dr. Ellison made fun of him because he was saying it's Al something like Al ports, and Dr. Ellison was like, no, it's not Calcinoria. He's like, I was close. He's like, no, you weren't.
Oh, really?
Yeah. And then he kept going.
But James wouldn't let that stand.
Alright. So what do you think? Something going on, right? That doesn't look like normal collagen bundles, right?
No.
In the dermis. It looks like pink, amorphous, eosinophilic material. And if there's that much of it, it's probably what? What type? So it's amyloid, which we all know. But what type do you think gives you that amount of amyloid?
Nodular.
Nodular. Good. This one doesn't have really great plasma cell bundles, but sometimes you get them and sometimes you don't. Okay?
Do you have a vertical streaking with amyloid as well? Like lipoid proteinosis? Kind of vertical.
Yeah, how do you differentiate those?
So, well, you'll stain because the lipoid proteinosis won't be Congo red positive. So you'll do the stain. Like we will very rarely just straight out call amyloid on an H&E. We want to prove it because there are a lot of mimickers. And sometimes you think it looks amorphous and acellular, and then you stain it and you're like, not really amyloid. So we will stain it. But for these purposes, and since we're in the metabolic chapter, but yeah, on some sort of test, they're going to have to give you something else. They're going to have to give you a Congo red,
Or they just won't put
a perfect
the
history.
differential.
Okay.
Yeah, something like that. So they can't be. They have to give you enough for you to make a diagnosis. Okay. All right. I'm like the worst person at keeping this screen in focus. Sorry. So, what do we think? Fairly thick, right? We think normal, abnormal, what?
Dermis is a little busy.
Dermis is a little busy. Good. Do you think that the collagen bundles are arranged appropriately?
Sure. They're pretty normal.
You don't think that there's maybe a little bit too much space running through here?
Yeah.
So they're a little widened. They usually are a little more closely packed together. And over here, you definitely have a busy dermis, right? There's too many cells in there, and they're not inflammatory cells, right? These probably are around the adnexal structures, but all these intertwined in the interstitium here are not. So, busy dermis, widened collagen, thickened biopsy. What are you thinking? Scleromix. Good. So, what is scleromix associated with? Yep. What kind? IgG lambda. Good.
You guys know because that's the Y, like myxedema, and like trying to put that
down.
And it's a mix of everything in derm pass, so that's what's in the waste.
And then what would be your biggest differential in this? Yeah, so good. Nephrogenic systemic fibrosis. And so you need history, pretty much, to tell you, because histologically they're gonna pretty much look the same. So you gotta go with history. So yeah, on your test, it would be really mean of them to not give you any history and to stick both of them in the answer choices. If they do that,
Does the NSF like deeper is like one of the clues, or like if they do
not necessarily.
Okay.
So even, it's not the best down here in this biopsy, but there still are too many interstitial cells
Okay.
compared to some of the other ones. But from...
Starts at the top. Is it also like Scleredema like starts at the top and goes down or something? I don't know. Which this example fits with that, but I don't know if they're...
Yeah,
like
I
this,
just
like-
know that histologically, without any history, they're both stuck in your differential. So, any questions about Scleredema? All right. Number 11.
Straight out of the textbook.
So what is it?
Like,
Lichen amyloid. And why is it lichen amyloid? So, amyloid, for sure. Okay.
and then they're rubbing.
Yeah. So you've got hyperkeratosis and acanthosis. You've got either pigment incontinence or hemosiderin kind of rimming it. So those are all nice clues. So good.
What?
MEN2A. Like in
And then
Might be out of the book as well.
Mm-hmm. Okay.
For sure.
Scrotal calcinosis.
Okay, so how do you know it's scrotal calcinosis? Other than this is the slide from the book.
So it's two eyes
You
looking
got
at you.
rugated.
Because they're not going to do that to you on your test. Promise.
You got rugated epithelium.
oh, that smooth muscle high up.
Well,
Yep. So those haphazardly arranged smooth muscle bundles, right? They're not pilar or erecti muscles because they're not lined up appropriately, right?
Mm-hmm.
So those are all over the place and they're fine and wispy. And this is calcium. Ours is generally more purple here.
Ours is like dark purple. It's
Yeah.
weird.
This may have had to have been decalcified in order to cut it, so that might have something to do with this as to why it is so good. So, any questions about scrotal calcinosis? Okay. What do you guys think from low power? Not much, right?
Not a whole lot.
Dermis is super thick.
So the dermis is a little thick.
It's deep,
That-
never ending.
Yeah, that could be site specific as well.
Myxedema.
So yeah, so all of this stuff is your hint up here.
Good call.
So,
I think it's clear.
They probably have both. Don't worry about it.
Yeah,
I mean, like, they're diabetic. They got a little bit of
They're
early
itching,
severity
they're-
on there, and there's some macular amyloid because they're itchy because they're diabetic. It's fine. Like,
so yeah, but it's all these.
They're both on the normal diff.
yeah.
So it's very sparse, and if you aren't looking for it or aren't paying attention on higher power, you could completely miss all of this.
So you look at your answer choices, and then you go back and you look to see.
Sure.
Except the real world doesn't give you answer choices.
Yeah, but only two of us in this room. Or I guess
That's
three.
true.
in my room.
That's true.
They give you a differential.
So the other thing that might catch your eye is all the pigment incontinence, right? So when you start seeing pigment incontinence, it means that you should probably go look up in the papillary dermis and the epidermis a little more closely. So that would be your hint here. Okay? And the type of amyloid for this one? Yeah, so keratin derived. So it doesn't really mean anything as far as systemic wise. Alright, so 14 had 2 slides. I'm not sure why we have 2 slides, but we do. So what do you guys notice?
Calcium.
Calcium, good. So you kind of have pseudoepitheliomatous hyperplasia. You have calcium deposited subepidermally and kind of maybe being eliminated. Transepidermally. I think the other one is a better slide. That's better stained. So, what's, patient population and site that you're usually looking to see this? So, yeah, so good. So heel of the newborn or chin of a child. It's pretty specific. Very few other things kind of look like this. So, any other questions? So subepidermal calcified nodule. Last one. So what do you guys notice? There's something, there's something in here, right? So, the epidermis doesn't particularly look that concerning or that strange, but there's something deposited in here, right? And then the question becomes, is that gray blue stuff what or what? So mucin or solar elastosis. And is a colloidal iron going to help you? No. Why? Because it stains them both.
Because you said so.
So because it stains them both. But this one looks a little thin and wispy, and when you get outside of this area, you can see that clearly looks like solar elastosis, right? So the elastic fibers look thicker and chunkier and more discrete versus all of this over here, right, which is thin and wispy. So this is more likely mucin, right? So typically these are more dome-shaped, and it's just like the pool of mucin. So this is just focal cutaneous mucinosis. So any other questions?
Perfect timing.
Just
Nope. All right.
at the end.
Huh? Yeah, right. Last slide.
I looked at the wrong schedule. I thought we were doing February today.
All right, so that's all for unknowns.
Go.